हेलो।
Hello.
Hello. Yes, sir. We can hear you, sir.
मैं कैसे शेयर करूंगा इस पेपर?
सर आप ये तो इसमें एक स्क्रीन शेयर वाला ऑप्शन है। आपको ग्रीन में दिख रहा होगा नीचे शेयर, या फिर अगर फाइल आप मेरे को भेज दो, इधर चैट वाला ग्रुप होगा उस पे, या व्हाट्सएप पे भेज दो, तो मैं स्लाइड रन थ्रू करते रहूंगा।
तो एक मिनट करते।
हाँ सर, स्क्रीन दिख रहा है आपका, आप खोल सकते हैं प्रेजेंटेशन। सर आपका फेस आधा दिख रहा है, थोड़ा सा कैमरा नीचे कर लीजिए। यस यस सर, नाउ इट्स बेटर।
कैन वी सी
Can we
नाउ?
see now?
यस सर, वी कैन सी। सर आपका दूसरा वाला जो ब्लैंक है वो म्यूट कर दूं, क्योंकि वॉइस इको हो रही है।
हाँ,
बिल्कुल।
ओके।
Hello.
यस सर, वी कैन हियर यू नाउ सर।
Now today we'll talk about the recent advances in the neurosurgery. We talk about one by one topic. Can you hear me?
यस सर, वी कैन हियर यू
Okay.
क्लियरली।
Because so initially we'll talk about the spine because there are a lot of the things has been come in the spine. One is endoscope, second laser, and the third is subpercutaneous lumbar disc surgeries and endoscopic and minimal invasive surgeries. This we usually do for the disc herniation. Okay. Now question comes, how we diagnose the disc herniation and what are the symptoms these patients have. Usually these patients have neck or back pain with initially in the localized to that place, and gradually it is radiated to the limbs. We may be right or left and associated with numbness and the tingling sensation and the followed by the weakness. Sometimes there is involvement of the bladder and bowel sensations. So question comes, how to diagnose this? If we find these kind of symptoms, pain which is radiating and with the neurological deficit, better to do MRI. MRI is the best investigation to be done. Initially, we can do X-rays and other things, but the MRI is the best investigations. So now comes modalities. This is we are using percutaneous injection and discectomies. We make the patient to lie on the side, and then we do by percutaneous under the C-arms. We go inside as the showing the presentation by how we go inside, and we can remove contained disc. This is good for how it looks during the surgery. We find we take out the disc fragment and free the nerves. Okay, but this is procedures only done for the contained disk, when the disk is contained inside the uh, disk material. Then next, I'll show you the MRI, how it looks. This is, you can see the MRI, there is a disk
Sir,
coming
sorry,
out. This is
sorry to interrupt, sir. Sir, can you make it full screen, like the presentation, full screen view? So there will be F5 function or full screen optionality there, where only the slide will come, sir. Yes, sir, slide. So from current slide, sir, second option from the left, yes.
now okay.
Yes. Now, okay, sir.
Yeah. Now you can see that the disk has come out. This is a minor disk bulges. This is a major disk bulge here. Now in this scan, we can see this side the disk is prolapsed here, compressing the right side nerves. So in these cases, if the now we initially manage with them conservative treatments, give physiotherapy, painkillers, muscle relaxant, rest, and some physiotherapy like ultrasonic, diathermy intense. And if the patient is relieved by this, even can follow by at least some period of the rest, bed rest. Usually patient relieved by these symptoms, so we can carry on. Now the red flags are there. One is a bladder involvement. If patient have problem with the urine and passing motion. Second is any weakness, gross weakness, foot drop. Then we go for early surgery. Now we prefer to the surgery by this endoscopic, minimal invasive. We make small incision and we go by the with help of the dilators, and with the under the microscope we operate this patient. We got a setup like this, and I'll show video how we operate. This is a dilator and retractor we have placed. Small tissue we remove by the cautery. Once we have removed that, then we'll use the microscope. Now we are using microscope. We are taking the small dissections. So now we are cutting the ligament there. This is called flavum ligament. We cut it. Now by the nerve root retractor, we are retracting the nerve. So we have opened the annulus of the disc. Now we are removing the disc, which is compressing the nerve root. Now we are removing the extruded part of the disc, which has gone below the nerve root. So after the removing the disc, the patient usually do well. So next is kyphoplasty. When we do the kyphoplasty, is compression fracture in the vertebra. Here we can see the compression fracture. You can see in the MRI, you can see on X-rays, the body get compressed, especially in the osteoporotic bone fractures or some secondary to disease, it can happen, especially in the old ages. Now, initially we used to treat this kind of patient with a bed rest, give calcium, vitamin D and other conservative, and to make the more calcium in the bone, we can give androgenates and other like PTH hormones and other calcitonin hormones. But as you know, the osteoporotic fractures and osteopenic fractures very difficult to heal now, and because they are quite painful. And if we allow the patient to walk regularly, they may compress more, and uh, compression on the nerves may come and they become neurological deficit. So what we do, we put a small procedures, and by that we put a cement inside. We call it a kyphoplasty. The advantage of this procedure are because immediately 90% pain is gone. Second, we can mobilize the patient from the next day so he or she can carry out his normal daily activities. That is a wonderful procedure, especially in the osteoporotic fracture where the bone posterior margin of the vertebra is intact and there is no compression on the cord or nerve roots. This is also one of the cervical disc problem. If you see the X-ray here, is the cervical disc comes, and when it compress in the cervical region, patient may have neck pain, may have upper limb pains which is radiating. Third is that patient may have weakness in both upper limbs and lower limbs, and patient is difficult in walking, sometime involvement of the bladder valve. Initially, we used to operate by them. Uh, Once we try the conservative symptoms are minimum, no gross neurological deficit, motor or sensory. And then now we latest we are doing the disc replacement. You can see is the here, we have replaced the disc. Now, advantage of the disc procedure is that the patient can move the neck from the first day. He can move from any time. There is no problem with the, he has not to wear the collar for a long time, and neck mobilities from the early, he can join his job or early. So this is the video of disc replacement surgery. This is, we have opened the neck. Now we have removed the disc from here. Then we apply the two retractors. Now we are removing the last part. This is the newly artificial disc. We call Bhagira. Our name is the disc of the artificial is Bhagira. It can be easily placed in the space which has created after removing the disc. Once we applied, we'll remove this hole. Now under the X-ray, we can see the movement at that level. Okay. This is the fracture of odontide. The upper bone has got fractured here. We can see this fracture line, and if see the MRI once we do in the flat position, so it get reduced. So what we do for this kind of surgeries, because these have severe pain here, so what we do, we put a screw from the anteriorly open, which goes from the C2 and this odontoid and make it a fixed line. So only one screw we can put in the fracture through the fracture and fix the C2 with odontoid, and we can preserve his movement on the spine. These are the X-ray during the surgeries. Now I will show the video of the surgery. Now I'll show the endoscopic procedure. What we do in endoscopic brain and spine surgeries, endoscopic we do for hydrocephalus third ventriculostomy. Sometimes multiloculated, we do fenestration of the cyst. Sometimes with small tumors in the ventricle, we take out this. And one we do transpinidal surgery and microvascular decompression. So I'll show how this is the presentation of this ventricle is passed from the by making a small burr hole in the lateral ventricle. Then we can pass in third ventricle and make a hole in the base of the third ventricle. This is called third ventriculostomy. This is the representation. We got irrigation and the visuals, how we get the visuals. So these are the sites we presentation. Now I am showing the video of this called colloid cyst. Colloid cyst is a benign cyst at the junction of the lateral and third ventricle. It blocks the passage from the fluid from the lateral to third ventricle. Patient get a severe headache and they become faint, and sometimes mortality may take. So these are the two procedures which we can do by the surgery, microsurgical excision of third, but we need to open a big portion of the brain and carries high mortality and morbidity. Second is that we can do by endoscopic surgeries. We make a small burr hole and put endoscope inside, and then we remove this colloid cyst, decompress the cyst, and open the. I'll show the video of this. This is a colloid cyst. You can see here. It is blocking both the ventricles. This is the video. I'll show you. We have made the burr hole, small burr hole. Now we are putting the endoscope in the brain. Now we are going to the lateral ventricle. We can see this is foramen Monro, this is choroid flexus. Now we see the interventricular septum, which is very thin and flimsy. So now what we'll do, we'll make a hole in the septum so we can communicate both the lateral ventricles first. This is, you can see, we are not able to see the structure of third ventricle, which has been blocked due to colloid cyst. Now we are using, this is called bipolar cautery. We make a hole in the ventricle. Now we have opened this colloid cyst. This colloid material is coming out, which is sucking with the catheter. Suction catheter we are using. We are taking this catheter, sucking this material out, so we can decompress the cyst. Now with a gentle traction, we are pulling this cyst into the from the third ventricle into the lateral ventricle. So now we have almost taken out the ventricle. We're trying to see anything remnant in the. Now we are with the slight traction. We are pulling this out. This is the choroid plexus from the opposite side. We coagulated it. Now we can see the floor of the third ventricle, which is clearly seen in this picture. So it shows there's a now foramen magnum, foramen Monro's has been decompressed. Lateral ventricles are well communicated with the third ventricle. So our purpose is solved by this small hole, and with the help of endoscope, we can remove the colloid cyst. These are the other picture of the colloid cyst, how it looks. And these are the post-op scans. Now ventricles, we see the ventricle has been decompressed, cyst has gone. Now one more thing is the stereotactic surgeries. When we do the stereotactic surgery, this stereotactic is a coordinated surgery. When the any deep-seated lesion in the brain, what we use a stereotactic frame. We apply on the head a frame, and then we take a coordinates like X, Y, Z, and by making small holes, we can reach to the deep-seated small lesions, and we can help in the Parkinson disease. We can place the electrode with the help of this. So this is a frameless stereotactic. In this, we don't apply a frame. We take a target, and with the fiducial marker, we can plan and we can take a biopsy with the frameless stereotactic surgeries. This is the presentation of neuronavigation surgeries. When we do, we store the image and we can guide it by surgeries. So advantage is that we can do small craniotomy, and with the help of neuronavigation, we can take the tumor completely out, and we can mark the tumor before surgery, and we can plan the craniotomy better, and we can take the surgery tumor out. This is how we do stereotactic surgery in our setup, and we remove the tumor completely. This is the one more advantage that we use a fluorescence during the microscope. We give a yellow dye before surgery, and when we go inside the surgery using the yellow filter, then we find the tumor becomes change in the color. So we can identify the tumor easily and completely can take this tumor out. This is the one of the new modalities which helps to identify the tumor and helps in completely taking out the tumors. Especially it is very important when the tumor is located in the very important areas or eloquent areas are where like the power, speech and anything. Just we want to not to explore or wonder much areas. We want to just only the tumor area. Hello, any question?
Sir, generally, they will write on the chat, and I will
Okay.
share when the questions are
Okay.
there.
One more is a trigeminal neuralgia. It is a very common problem, and it is a very troublesome problem. It is not life-threatening problems. Sometimes the patient have severe pain on the face, maybe in the near the eyelid, or maybe below the eye, or towards the. You can see this is area of the V1 distribution. This is V2 distribution. This is V3. Recently, we have operated. The patient has only pain in the tongue. On the right side. We have operated and patient was really in these surgeries. Common causes of these pain make the life of the patient very hell. Patient can't shave, can't brush tooth, drinking, eating, everything becomes very difficult. And even sometimes the cold sensation or air can cause severe pain. So they patients are uh, very annoyed with this disease. But initially we try with the medications. But as you know, sometimes the medication works, sometimes we require very heavy dose, so they cause side effects. And sometimes in spite of the medicine, the patient is not relieved. We have in between tried new methods like radiofrequency ablations, glycerol injections, and even gamma knife. But still, they are not very successful. And if they are successful, the success lasts only for 6 months to 1 year. The pain return back. Now we are doing with the microvascular decompression surgeries, where we decompress the nerves, and the pain 90% patient get relieved, and this is almost a permanent cure. Relapse are very less. So I'll show how do we these surgeries. In the cause of these surgeries are sometimes is the tumor there. Majority of time is the vascular loop, sometimes venous loop or arterial, which is compressing on the nerve, cause the demyelination in the nerves. That is cause of this. Another disease, demyelination, and other is the tumors and compression bias. So I'll show this is the MRI which is showing the nerve compression. Here we can see the bilateral compression, but here we want to do, these are the spatial sequences of the MRI by 3D CIS and the MPR which is required to find out this. So now in this MRI, we can see the detail which is compressing. Now I'll show the video of the surgery, how we do this surgery. We have done a small craniotomy here. Now we are detecting the cerebellum to see the fifth nerve. Now one vessel ICA has come. Anterior and inferior cerebral artery has come in the view. We'll distract it, and now we can see the fifth nerve. Very glistening now is fifth nerve. We can see vascular loop touching on it. This is the culprit which is causing vibration on this. Now we have separated it, putting a small patch of the Teflon, but we usually use Teflon, but in this case we are using the Dacron patch. We will put between the artery and the nerve, and after that patient surgery is completed and patient can be relieved the pain. 90% results are there. This is one of the wonderful procedures. And pains are, this is the photograph of that, how the vessel was compressing on the nerve. You can see their contact is indentation of the nerve, which is causing the trigeminal neuralgia. One more new modality has come, is a glial wafer. Everybody know the GBM is a very malignant tumor in the brain, and there is a life expectancy is less than 2 years. So once we operate the patient, we give radiotherapy and chemotherapy like temozolomide. Tumor come back maybe 6 months, maybe 1 year, maybe 2 years. Now if we are doing a recurrent surgery for the GBM, these are the chemotherapeutic wafers which can be put inside the operative cavity of the tumor. But it is costly. Like there we can see the recurrent tumor is here. Now we have planned to put a glial wafer, removing the tumor and putting a glial wafer there. So I'll show the how it looks like. A glial wafer is a button-like structure. We place this amount 5 to 6 or 7 sometimes. We put inside the, now you can see shape of the glial wafers. So after doing the surgeries, we put glial wafer inside the cavity. They slowly release the chemotherapy. It avoids the side of the chemotherapy, and so it is directly releasing the chemotherapy at tumor site. So better control. The tumor-free control is with this glial wafer is 12 months to 24 months. So this is one of the more arsenal has come in the field of the recurrent tumors. Now we can show. One is a focus ultrasound. By this, we can make the lesions. It is under a process. By this, we make a lesion like in the dystonias, refractory pains, and intention. But these are the destructive procedure. Once we don't, we can't revert back. Now, one is a deep brain stimulation surgery for Parkinson's disease. As you know, Parkinson's disease is an old disease due to lack of dopamine production in the brain. Why the symptoms are, as you know, they are difficulty in walking, tremors, rigidity, face-like maze, difficulty in walking, and the patient gets slowness in the body. Initially, we give the levodopa, maybe starting dose, and gradually we can increase the dose. Initially, the drugs usually work very well for few years. We call the honeymoon period of 4-5 years. After that, either we have to require a high dose of, due to we require high dose, which are more lead to the side effect of the drugs, or the effect get lessened. So what happens, the patient is having, he's taken the medicine, after 1 hour he again the same. So in this case we can do the deep brain stimulation where we put electrode in the subthalamic nuclei. So but the patient clinically improves, dose of the drugs get reduced, life become better. I'll show what we do in that process. We apply the frame, and intraoperatively we keep the patient awake. When we put electrode, we will stimulate there. Then we ask to do the movement of hands, legs, and we check whether we are at the right side or how much current we are giving, so patient can improve. If the site we find it, then we put a electrode, and the pacemaker is put in the interval of the chest, connecting to the leads. Now, one is the intervention MRI, intraoperative MRI we can use. It helps in the localizing the tumor, diagnosing, and complete resection of the tumors. One is, last I am talking about the gamma knife. How will it help in this? Small meningiomas, perioptic tumors, vestigial small tumors, especially AVMs. metastatic lesions and recurrent tumors. It helps. It gives a single dose radiation to them, and it can burn the tumor so that we can help it. And it is a really wonderful tool. Now, quite surgeries we can avoid, and we can do directly, like the cavernous sinus tumors, small CP angle tumors, your deep-seated tumors, or even the metastatic tumors, which are less in number. We can give a gamma knife, and they completely even can cure them. This is how the presentation of a gamma knife. Advantage is radiosurgery is that it is non-surgical, non-invasive, no head frame is required, good cancer control. Treatment usually session, maybe 1 or 2 sessions are required, and patient do well with these positions. One more topic, if you want, we can go by the robotic surgery in the spine.
Sir, up to you. I mean, it's a knowledge sharing session. It helps if you can
Okay.
cover it. We
Yeah.
have time.
Robotic surgery have been used in the recently in spine because it makes the placement of the screws and fixation in a perfect manner. So we can definitely localize the scene, and we can reduce the intraoperative radiation exposure to the patients and the surgeon and the attendant or workers in the hospital. In this, what we do, we take a data of the patient and we load in the computers. Then we do CT scan, or uh, we take the CT scan and the 3D X-rays of the patient, and we match with these data. Once we store these data in the patient, then we do the presentation of this. Now we can localize. Now the pictures are seen like this. We can plan this X-rays transpedicular, which angle we want to go. So once we have localized, it's me which is planning this. So once we have settled all this planning, then we set the arm, it comes and it guides where to put the screws. Now you can see with this help, we are putting the screws with the help of this, and we can directly see where the screws is going. Okay. This is our OT in the BLK where we're doing this surgery. Now we can see where the screws guiding to us. So it is a clear like 3D visualization of the screw placement. So here we put. Now we are seeing the screws are placed. So by this, you can see the screw placement identical because we have planned the screws are perfectly placed where we want to put them. So robotic surgery is rapidly evolving. Spine, it is only for the fixation of the spine is going on. Rest in the brain also, electrode placement can be done with the robotic help. That are we doing. That's still a lot of way has to go. So thank you for this my presentation. Now you can ask any question if you
Okay,
want
sir,
to ask.
there are a few questions, sir. So the first question is when you were discussing that neuralgia surgery. So it's from Dr. Brian from Lusaka, Zambia.
Yeah.
So his question is what complications are expected from this surgery?
For the trigeminal surgery,
Yes, sir. Trigeminal neuralgia.
because usually one complication is anesthesia complication. Sometimes anesthesia can react. That is a one part. Second, surgical part, we can make like hematoma in the cerebellum. Sometimes bleeding can occur. Sometimes infection, we can damage to the nerves. Luckily, our infection rate are very less. One patient, we developed the chemical meningitis. That we developed the hydrocephalus, and we have to treat with the shunt also. But rest of the patient did very well. Initially, it was a hitch, and few patients have complained of partially hearing loss because of some time initially period due to traction on the eighth nerve. Now we have do very less minimal traction, so we can decompress the nerve. So results are fine. complications are very minimal.
And sir, again, the question from Dr. Brand, what is the recurrence rate of the tumors?
Only 5%, not more than that. In our setup, we have not done any surgery. We have done more than 100 surgeries. We have not done again surgeries. But some patient might have mild symptom which can be cured with some medicine or assurance. Otherwise, it's a good result.
Okay. So now there's a question from Dr. Eshetu. I think he's from Ethiopia, if I'm not mistaken. And first, compliments to you for excellent updates, sir. And his question is, any recent advances in the management of pediatric congenital hydrocephalus?
Yeah, we are doing in pediatric congenital, we are doing endoscopic third ventriculostomy. But as you know, the success is slightly less with the endoscopic third ventriculostomy in a young age, because it is around 70 to 80% success. If we do shunt, programmable shunt, success rate is 95%. But shunt revision and infection, other parameters, then is a better choice to do endoscopic third ventriculostomy. Considering one, it is got succeed, then chances of any recurrence problems are very less.
Okay. Now, sir, okay, the doctor name is not displayed, but his question is time needed for full recovery and complications for trigeminal neuralgia treatments.
Neuralgia, we just keep 3 or 4 days with the patient, and patient after that, usually after surgery, pain has gone. So what we do, we continue the medicine for 1 month, and after that we stop the medication. So 3 4 days we keep the patient, we make the patient to walk from the next day, and they do very well. We do a CT scan post-operative to see what we have done, any bleeding, any collection, any other things. But as we know now, we are giving near a perfect result with that.
Okay. Now, it's from Dr. Atanda Solomon. He's from Lagos, Nigeria. First, congratulations for such a didactic lecture. And I'm not sure. It's about trigeminal. I think follow-up is there. What is the success rate of the surgery? Uh, okay, sir.
Success.
I mean, I think he's asked. Dr. Atanda, can you clarify which surgery? And the another question is, what's the financial implication? I think the third question is the screws inserted in the spine, are they absorbable? If
Yeah.
otherwise, then are they going to be removed post-op?
What I could not answer.
So he has many questions, sir. For first two questions, I have sought the clarification with surgery. But the third question is, you had covered those screws in spine under such surgery like robotic. His question
Yeah.
is, the screws that are inserted in the spine, are they absorbable? Absorbable?
They are not absorbable. They are non-absorbable. They will last. They will be present lifelong there.
Okay. So, for now, for question for his question number 4 is for chronic trigeminal neuralgia that is not amenable to medical treatment. What
Yeah,
surgical treatment is required?
no, 3 4 options are there. One is a radio frequency ablation. Second is glycerol injection. Third is a radiosurgery or gamma knife. Fourth is microvascular decompression. Initially, we are trying with the glycerol injection, radio frequency ablation, and the gamma knife, but the results was not so good. For the glycerol and radio frequency, once is the numbness on the face, 50 to 20% cases. Second, the pain comes back after 6 months to 1 year. Second, with gamma knife, it only relieves takes a long time to relieve and the partly relieve the pain, not completely. So patients are not happy. They are initially happy because surgery has not been done, but after all, the results is not good. So now we have again switched over to the microvascular decompression. For last few years, we are doing only microvascular decompression, no injection, no radiofrequency ablation, only in those patients where we can't do surgeries. So these patients respond very well. Number one, results are good. 95% are pain-free after the surgery. Second, complications are less than 1%. Third is that we can 2 or 3 days or 4 days hospital stay. Fifth is a cost effective. The medicine cost, if 1 year is costing around surgery, the cost here surgery is on our place is around $6,000 to $7,000. Next
Okay.
is that result is 95%, and we can stop the medication after 1 month. These are the uh, good facts about this surgery.
So, sir, his question is like for definitive diagnosis of this trigeminal neuralgia, what investigation can they do? So
Yeah,
they,
first is I told you, first the clinical diagnosis. Second, we have to do a good quality MRI with the CIS scans. Because CIS scans, we see the vascular loops. If they find tumors there, and if we can localize the vascular loops, that is a wonderful. We can diagnose where it is compressing the nerves. So good quality of MRI with the CISS sequences, these are the good to diagnose a trigeminal neuralgia.
Okay, so Dr. Solomon has clarified. He was talking about robotic surgeries in general, the area that you covered in the last. So, what are his question is what are the success rates of those, and what are the financial implications?
Yeah, financially, if we do a normal spine surgery, cost $7,000, then $1,000 to $2,000 extra with the surgery. But success rate is advantage is that the misplacement of the screws reduced to less than 1%. That is the main advantage. Because sometimes we do a good surgery, we place the screws. And if any of the screws are misplaced, then is a question comes the whole surgery significance lost. So that is the advantage where we put with the robotic surgeries because they are perfectly placed, no neuralgic pain, no complication with this. It makes the surgery more perfect. The results are very good. That's why the cost is not so significant, but it is only the screw placement is done by the robotic. Once it is more developed, they may be help in dissection also.
Okay, sir. So now another question from Dr. Al Mustafa Nuruddin. So first, sir, compliments on the very educative presentation. And I think his question is broad-based around a lot of surgical topics that you covered. So he generally, what are the success rates of these surgical procedures and the absolute contraindications?
Absolute contraindication, cardiac problems, any bleeding coagulation disorders, or any severe infection in the body, we will not do. Like trigeminal neuralgia, if patient is responding well with the drugs, will not do surgery because unless patient wants, we want to continue medication. If you are be controllable with minimum doses, that's good, fine, perfectly. We don't want any surgery. But if patient is pain is not relieved,
I think there's some network issue at Dr. Anil's end. Let's wait for a minute.
Hello, can you hear me?
Yes, sir, we can hear you now.
Yeah. So my video somewhere stopped now calling here.
So you
So
were explaining in that between, sir, about success rates and absolute contract in
yeah, absolute contraindication are any bleeding coagulation disorders where we don't do surgeries. If patient is like trigeminal neuralgia is completely relieved with it, yeah, we don't do surgeries. If the trigeminal neuralgia patient's pain are not relieved, then we do go by these surgeries. If,
Okay.
like this.
Sir, I with this I bring like a very question. So sometimes, let's talk about, sir, spine issues that you mentioned, like some nerve
Yeah.
compression through a minimally invasive surgery. Nerve decompression helps the patient. Let's say if somebody is elderly, 65 years old, showing signs, where in India we follow conservative treatment path that surgery unless absolutely necessary, like you also pointed out, the first is medication. So let's say there's a 65-year-old woman has nerve decompression and can be managed with physiotherapy and medication. But it's very clear to you as a surgeon that surgery may help because last 5, 10 years of life, which are left, if it can be pain free. So how do doctors make this cost benefit decision? To you as a
Number
surgeon?
one,
Yeah.
yeah. yeah. Number we see how much is the pain. How many tablets of the painkiller patient has to take in a week? If the patient is taking per day 2 or 3 tablets of painkillers, or he or she can't carry out his daily activities, he can't walk for 500 meters and other things, then we consider number one. Number two is if a neurological the weakness of the limbs and there is a bladder bowel involved, and then we advise them better to go for surgery. Long-term result and the financial will be better with this. Otherwise, you have to take a long-term medication that will cost you the same or even more after some time.
Okay. So, sir, incidentally, very recently, our team had shared a case with you from DRC, which was again this trigeminal neuralgia, and
Yeah.
they were getting some. I mean, they were from others. The doctor, local doctor, informed us that they were getting some, those fixes like plastic surgery or that kind of a thing. So, as you covered that topic, I mean, it is for education of the African doctor how they approach. Many times, surgical decisions are more cost
No.
effective done right.
Yeah, trigeminal neuralgia is a very complex disease because everybody treats by his own way. Sometimes some say don't require any treatment, the patient is feeling this pain, patient knows. But the patient is having severe pain. One of my patient used to tell me if he take a milk or anything by in one shot, otherwise he can't take. Pain becomes so severe he can't eat or feed by himself. So that is a question comes. These are kind of patient. I have done a lot of glycerol injection initially as an in a women's in the one of the pioneer neurosurgical hospital in Delhi, where I do more than hundreds. But every patient comes 6 or 1 years after that, still pain is come back and the same problem. Even the medicines, patient are taking 3, 4 medication, but they are still failing the 10 days of the month. They are facing the pain and that's hampering their job and the personality and their working environment. So considering everything on this, now we find that if we do microvascular decompression, I am telling you surgery for 6 month medication cost as equal to the surgery cost. So
Okay.
now we have done it this because the complications are less, we give good results. So long term, it is a financially benefited also.
And so many times we see cases like where craniotomy, like I'm not a doctor, I'm an engineer, so craniotomy, etc. If you can cover, because your discipline is surgery, while let's say a neurologist will take conservative medicine, I mean about any area, a conservative estimate, and there's always a choice patient is facing. Should I go
No,
for
no,
surgery?
no.
Yeah,
I'm telling you, it is a combined branch. It's not a neurosurgeon, neurologist. Everybody has to combine. And
yeah.
we go by the results, what is required, like Parkinsonism. Early 5 years period is neurologist has to treat because once the drugs are working well, no surgery is required. Once the patient is not responding to medicine or the drug side effect is coming or life become very compromised, then role of the DBS comes. But then we have to be on the same table that this patient is required because as we know, complication has reduced now. We are doing DBS. It is costly procedure. It costs a lot, maybe 30 to $40,000 in our setups. But results are so fantastic. Last month we have done it for a uh, dystonia patient. Patient was can't stand properly. One side was abnormal movements. We have done this from the patient from Yemen, and the patient did very well.
Okay.
That
So
is
now,
our advantage.
so, sir, as a like to understand, sir, I have one more question to you. So now in healthcare sciences, when I mean you look at more data than us, you look at more those peer-reviewed papers where these are things. So many times when, at least in those cases where surgical skill or the results have advanced a lot, so why do medicine science? I'm talking about the profession, like say for Parkinson's, if it is obvious Parkinson diagnosis is confirmed and surgery has good results that you mentioned. So the patient loses 5 years of life, quality
No, no,
life,
no.
not done
No, no,
early.
no, no. Question is this. No, no. Question is this. Initially, we treat with the medicine. Initially, medicine dose is required very less, and the patient do very well with this. But as the gradually disease progress, we have to increase the medicine dose. And
Okay.
after 3, 4 years, we have to increase the dose so much the patient has to take the drugs 4, 5 times in a day, and still is not comfortable
Okay.
on
So,
side effect of drugs. That is the ideal time to operate because it is not only surgery, it is a combined medical with the surgery. But we have to know the proper time and indication of the surgery. That makes it a perfect.
okay. Okay. Thank you, sir. So there's no more questions, sir. But I am telling the doctors, sir, that if you have any follow-up questions, they all have a work group with us. They can pose it to us. Many times, sir, they struggle complex cases. Patients are poor. They may not come to India for travel, but we tell them that you draft notes and share.
No,
Indian
you
doctors.
draft the notes, whatever help we can do from here, we'll do that.
And Dr. Anil, the main message that what we are doing is think of Jivo as a clinician alliance. So India's excellence, what
Mm.
is happening in medical tourism right now, that local doctors are bypassed. Patients originate their journey through commercial agents. What we are trying to nurture is that we make them, like Dr. Atanda here or whoever has joined, we make them the care custodians. Because part of doctor is counseling, identifying, triaging who needs help. And with this access to doctors like you, I mean, if you can speak to a few words about the sense of this approach, if it is inpatient
No, no,
interest.
this is a very proper system. The patient should go primary doctor, then secondary, tertiary doctors. And once we operated on some patient, he go back, he need the local doctors there for every help. We also want to guide this system because they need a good communication because they should be free to talk to us or you people if they are facing problem. We are facing with this patient, how we will manage that? Because that's a true sense we can treat this patient. Because once we are operated, patient is having post-operative complication there. I can't manage there. The local, even our towns, we come the small city, the patient comes, we send them back to the local doctor and we keep in touch with them. Because once they are in touch, the patient can be benefited more. That is the true sense which you are doing will help in this medical sector.
We
Because
just
our only target is not surgery, to treat the patient.
correct. And sir, your word of encouragement because you are among the like what I know because of the background. I'm Indian, so that what we call cream de la cream of India. I mean, a word of encouragement for this doctor because every good movement starts slow. So if we succeed in this, these people will be that example would be quoted that these physicians changed this, made medical tourism agent free. I mean, as a doctor, you can share your thoughts about it.
Yeah, definitely. It should be agent free. It's a requirement based. It number one thing we should be what we should do what is required. Number two, it should be done perfectly.
Thank you, sir.
That's what we want because it involves your reputation, my country reputation. So we want to do this good for the patient. We want to give the, we will not treat unnecessarily anybody for the money. Okay?
Okay. Thank you, sir.
Thank you.
Thanks a
Okay.
lot for your time. And thanks for sir joining this masterclass, for agreeing. Thank you, sir. And
Thank you.
thanks all our doctor partners from Africa. I know doctors
Uh,
need only Sunday for their family, and we bring you for medical discussions. But I think these are needed and necessary. Africa to India corridor should be run by doctors and not agents.
and to show my dog, which is
Yeah.
lying with me.
Oh,
It
oh, you
is
have a
it
lepra,
is
sir?
yeah.
Yeah.
He's taking my time with the side.
Thank you, sir. Thanks a lot.
Thank you.
Thanks a
And
lot.
thank you everybody for this. Okay. Thank you.
And just one message, if anybody has any patient, struggling patient, feel free to share case notes. We'll share with Dr. Kansal. Not everything is about travel to India only, but we Jivo wants physicians like to be held by access to doctors like Dr. Kansal. And please feel free to share any case notes about any relevant patient, which might help you. Thank you. Thanks a lot.
Thank you. Bye. Thank you. Bye bye.